Hello and welcome to Internal Medicine, where we talk about internal medicine topics and emergency medicine topics. Today we're going to be looking over a couple of slides that I prepared about lithium toxicity. The goal is to help you with patients that have lithium toxicity, as well as assist you in answering board review cases. So without further ado, let's get started.
A 35-year-old woman with bipolar disorder presents to the emergency department with nausea, vomiting, diarrhea, and tremors. She has been on lithium therapy for the past 2 years. On examination, she appears dehydrated, and her neurologic examination reveals a coarse hand tremor and confusion. Blood work shows the following: sodium, 135 MEq/L. Creatinine, 2.1 mg DL. Lithium level, 2.8 MEq/L. Therapeutic range, 0.6 to 1.2 MEq/L. What is the next best step in the management of this patient? A. Increase her fluid intake and monitor. B. Administer sodium polystyrene sulfonate. C. Start hemodialysis. D. Administer activated charcoal. E. Prescribe lorazepam for tremors.
So lithium toxicity, the mechanism, it alters neurotransmitter activity. It decreases the release of norepinephrine and dopamine from nerve terminals and may transiently increase serotonin, resulting in mood stabilization. So that's its purpose. The neurotransmitter effects can give you a sense of what type of symptoms you're going to be looking for with these types of patients. So norepinephrine, dopamine changing, increases serotonin. We're going to see probably neurological changes. We're going to see cardiac effects. Pharmacokinetics of this, it acts similar to other group 1 alkali metals, sodium, potassium, and this will become important pharmacologically when we talk about, pathophysiologically when we talk about how patients have toxicity from lithium. Its peak levels within 1 to 6 hours of overdose, and there's a sustained released form that peaks within 6 to 12. So the preparation that the patient's taking really matters and affects toxicity. If you look at their half-life, it's 24 to 29 hours, meaning if somebody overdoses on this, they're going to be admitted probably for a few days in order to have these levels monitored. A 300 milligram tab contains 8.12 milliequivalents of lithium and raises a level approximately 0.1 to 0.3 milliequivalents per liter. A fatal dose of lithium carbonate is 40 milligrams per kilogram. So doing a little bit of math for us, if we have a 70 kilogram person, that's going to be 2.8 grams. If we divide that by 300 milligrams, which would be a standard pill, a patient only has to take 9 or 10 of these in order to have a fatal overdose. Elimination, 95% of it's done by the kidneys. This is going to give you a hint about what type of organ system dysfunction affects pharmacokinetics of a lithium toxicity, as well as how you can end up with lithium toxicity if you don't intentionally overdose. So let's talk about that for a second. There's intentional overdose and then there's unintentional overdose. Intentional overdose is pretty straightforward. A patient comes in, they say they overdosed on lithium, or they're having neuropsychiatric symptoms and they're having an arrhythmia, and there's lots of empty bottles of lithium around. A board question could frame just saying that the bottle's empty, or they could give you hints based on what the patient's past medical history is and what medication they have access to. It's the unintentional overdoses, I feel, that get missed, and it's something for internists to think about when they're prescribing medications, as well as emergency room physicians. So when you have a patient on lithium, you want to avoid lithium toxicity by thinking about a few things. One is, like I said, lithium acts similar to other group 1 alkali metals. So any situation in which the body's reabsorbing sodium, you're also going to reabsorb lithium. So this is going to be states of dehydration. This is going to be NSAID use. This is going to be patients that are placed on diuretics. These are patients that are going to suffer acute kidney injury. So patients can have an unintended overdose with lithium simply by taking additional medications, like I said, NSAIDs, ACE inhibitors, or by pre-renal states and dehydration and acute kidney injury. So a 60-year-old patient that comes in with acute kidney injury and has a creatinine of 2.5, you hydrate them, you're thinking about maybe just sending them home. If they're on lithium, that's incredibly dangerous in their situation. So you'd want to make sure that they return to a normal GFR before restarting their lithium, as well as you'd probably want to check a level of it before making any disposition decisions. Moving on to signs and symptoms, like we said, there's stages that go along with this and then some general symptoms. So let's start with the general symptoms. There's gastrointestinal symptoms, nausea, vomiting, diarrhea, ileus. So lithium toxicity or overdose should be on the differential for GI problems that are kind of outside of the gastrointestinal tract. Neurological changes like muscle weakness, tremor, rigidity, extrapyramidal symptoms, increased deep tendon reflexes, agitations, and then seizures seizures and coma would be more severe neurological changes. Cardiac changes, you can have bradycardia, you can have QT prolongation, which can lead to polymorphic VTAC or torsades. Wandering atrial pacemaker is another cardiotoxic symptom that goes along with lithium. What is this? Hansen and Anderson. There's a classification system, like anything's named after people. And this relates more to chronic toxicity, but it highlights some of the stages and gives you a rough correlation of lithium levels that correspond to these symptoms. So stage 1's more mild muscle weakness, nausea, vomiting, diarrhea, some tremors, correlates with a lithium level of 1.5 to 2.5. There's stage 2, which is moderate disease. Now we're moving into confusion, some dysarthria, ataxia, myoclonus, and then you might see EKG changes here. Stage 3 is severe seizures, coma, like I said, the more severe neurological changes than cardiovascular instability, and that's associated with a lithium level of greater than 3.5. Chronically, patients can have toxicity from lithium that can manifest in different ways. For an emergency medicine physician, you may want to know some of this because it may give you a reason why they have some of these disease processes and new onset if you're diagnosing them. Or for our internal medicine folks, these are things to look out for chronic toxicity. Some of the chronic symptoms, some of the chronic disease states that result from lithium toxicity would be diseases like silent, which is syndrome of irreversible lithium effectuated neurotoxicity. So that's hard to remember, so they shortened it to silent. So it results in permanent neurological sequelae after toxicity. So even after an overdose, patients may have long-term neurological changes. Renal changes, you can get acute and chronic tubular interstitial diseases or interstitial nephritis, diabetes insipidus. You can get hypothyroidism as well as hyperparathyroidism, and it's toxic in utero, causing Epstein's anomaly. So let's look at a workup for a lithium overdose. You may notice some laboratory changes that are associated with lithium toxicity. This would be hyponatremia. You could see an elevated BUN to creatinine ratio. What you'll also notice is these patients will have a low anion gap, which is a weird thing. This comes from the addition of positively charged ions. So other conditions that can lead to this misbalance, leading to leading to a low anion gap, would also be things like hyperparaproteinemia, which would be multiple myeloma, hypercalcemia, and hypermagnesemia can also lead to additional positively charged ions. Just to round off the rest of the differential for a low anion gap, hypoalbuminemia can lead to this, as well as there's some laboratory error that goes into an overestimation of chloride from things like bromism or iodism. So those are other forms of toxicity that leads to a low anion gap. Since we don't really talk about low anion gaps very much, I just thought it'd be helpful to go over a quick differential for that. A CBC might show leukocytosis from stress, as well as some of the direct lithium effects on bone marrow production. EKG changes are T-wave inversions, U-waves, and then that all too well-known QT prolongation and bradycardia. Lithium toxicity can be staged based on serum levels. A therapeutic index is between 0.6 and 1.2 milliequivalents per liter. So it has a very narrow therapeutic index. And then lithium toxicity, as we said on the previous slide, which can correlate with chronic toxicity, would be mild to moderate symptoms at 1.5 to 2.5, severe at greater than 2.5 to 3.5, and then the life-threatening ones at over 3.5. So what do we do for treatment for these patients when they have lithium toxicity? Well, GI decontamination, it would be a cornerstone, but it depends when you catch this patient. So charcoal is going to be completely ineffective. It does not bind to lithium, as well as it does not bind any other heavy metals. So charcoal, which is a cornerstone for decontamination, you kind of have to throw out the window and can't be used. Depending on when you catch the patient, if they've come in within an hour of their overdose, you can do GI lavage or whole ball irrigation. Whole ball irrigation is still helpful if the patient took a sustained release product. The goal is just to suck out whatever the person's overdosed on or wash it out before it's absorbed as quickly as possible. You may read or come across some literature referring to Kayexalate being used as a cation resin. There's some theoretical benefits to this. I've never actually seen it used. I've only read that it's rarely used. You might see board questions that kind of throw it on maybe to confuse you a little bit, but I just wanted to cover it. So I won't see it used, but you may come across it in the reading. So I just wanted to address it. For treatment for elimination, depending on the patient's severity of symptoms, we would start with intravenous fluid to try to wash it out as quickly as possible before there's neurological and cardiovascular effects. But hemodialysis may be indicated depending on the patient's symptoms and then the level of lithium. So looking over indications for nephrology, this would be something you probably want to discuss with nephrology immediately. In my experience, they seem to seem to have a very low threshold for doing hemodialysis with lithium toxicity. But indications would be any lithium level greater than 4, kind of regardless of symptoms, a 2.5 to 4 with severe neurological or renal insufficiency, level of less than 2.5 with severe kidney disease or other comorbidities that would make hydration difficult. So if they had an ejection fraction of 20% and their creatinine at baseline's 2.5, then they're probably not going to tolerate hydration all that well. As that chronic kidney diseases make the patient retain more lithium. So the threshold kind of depends on what the person's kidney function is, what the lithium level is, and then what the patient's symptomatology is. So based on those 3 things, you should be able to make an educated guess if nephrology is going to want to do hemodialysis on a patient. Well, great. I hope that clears up any questions you had about your lithium toxicity patients. I hope it helps you answer any board review questions you get correctly about lithium toxicity, and thanks for watching.
Correct answer, C. Start hemodialysis. This patient is experiencing lithium toxicity, characterized by gastrointestinal symptoms, neurologic findings, tremor, confusion, and elevated lithium levels. The high lithium level, 2.8 MEq/L, and impaired renal function, elevated creatinine, warrant immediate intervention. Hemodialysis is indicated for lithium toxicity, particularly in cases of severe symptoms, renal dysfunction, or serum lithium levels greater than 2.5 MEq/L with signs of toxicity. Increased fluid intake, A, might be appropriate for mild toxicity without renal impairment but is insufficient here. Sodium polystyrene sulfonate, B, is not effective in lithium toxicity. Activated charcoal, D, does not bind lithium and is therefore not useful. Lorazepam, E, may address tremors temporarily but does not address the underlying toxicity.